Morning everyone. So this presentation is to give a broad overview about the management, the evaluation and management of children with spine injuries. So just to have an audience response system questionnaire. So that's the question. What is the most common level of pseudo-subluxation in the pediatric spine? So there are 4 options for you: A, C1, C2, C2, 3, C5, 6 or C6, 7. Right. Thank you for the response. Right. So I think you have heard this statement time and again in the last 2 days. So children are not small adults, and that statement holds good for the management, especially for the diagnosis of children with pediatric spine injuries. So what we are dealing is not just about small bones. It's a lot of differences exist. So these are some of the important things which you should know. The normal anatomy itself is different. So the normal synchondroses, which are the growth plates which exist between the ossification centers, can be confused with fractures. And normally children have a normal anterior wedging of the vertebral body, so they should not be confused with compression fractures, and pseudo-subluxations exist. So radiological interpretation can be difficult, and clinical examination can be challenging. So the incidence is very less, as told. So it is about 1.5% of all pediatric trauma. But one important thing I would like to highlight is that in adults, cervical spine injuries are much less common. They occupy about 1/3 of the injuries, whereas in children it is much more common, about 3/4. So this is an important thing. So 8 to 9 years can be considered as the watershed age, because most of the normal adult morphometry, about 90% of this is achieved by 8 to 9 years of age. So spine injury beyond 9 years can be similar to an adult pattern, whereas less than 8 years, the pattern is different. So if you look at the normal relative proportions for a child and an adult, so as you can see, the child less than 8 years has a larger head and a smaller torso, whereas as we become bigger, we have a smaller head and a bigger torso. So less than 8 years, almost 75% of injuries occur in the cervical spine, and most of them are situated around the upper cervical spine. So the incidence of neurological deficit and coexisting head injuries, so the morbidity and mortality is higher in these children. So one key thing when you examine these children in casualty, if a child is less than 8 years, because of the larger head, don't place the child in the normal spine board, so the head goes into flexion and the injury gets worsened. So keep the child where you can have an adequate additional backbone under the torso, or you have a recess under the occiput so that the neck is placed in extension. So the biomechanics significantly differs between a child less than 8 years and more than 8 years. So inherently the child less than 8 years has an unstable cervical spine because of increased ligamentous laxity and horizontal joints. And there are a few open synchondroses that exist, and the fulcrum of stress happens at the upper cervical spine. And more than 8 years, it is more like an adult spine, where the ligaments generally become strong, the synchondrosis fuse, and the fulcrum of stress happens at the lower spine. So when to get a radiograph in a child who presents with a suspected cervical spine injury? So there are no standard criteria like the nexus criteria, but these are the standard indications. Any child with who complains of a neck pain or focal tenderness after an injury, when there are transient or complete neurological deficit, significant distracting injuries are there, any child who is inconsolable and crying, and an unconscious child. And interpreting the radiographs is the key thing. So get multiple opinions from your seniors or specialists in spine. And while interpreting the radiographs, especially child who is less than 8 years, you should know about the synchondrosis. So normally we have 3 ossification centers for every vertebral body, every vertebra, 1 for the vertebral body and 2 each for the posterior arches. And in these children, so please remember this 1-3-6 rule. So 1 refers to the first year where all the 3 ossification centers appear. 3 is the time when the neural arches fuse posteriorly. And by 6 to 7 years, all the 3 synchondroses have to fuse with each other. So more than 8 years, you don't see the synchondroses, and less than 8 years, you should know when these appear and when they fuse with each other. And one exception is the C2, where you have an extra dentocentral synchondrosis between the dents and the body. And this can be confused with a fracture, and this usually fuses with the body at about 6 years. But a child less than 6 years, that can act as a source of a weak link, and this can result in a displacement. So such children will need a fusion. And second thing is to differentiate a pseudo subluxation from a true subluxation. So to identify this, you need to know about the Swiss check line or the spinolaminar line, which is usually drawn along the spinous process and laminar junction. So for example, as we discussed earlier, so C23 is the most common site of a pseudo subluxation. So this child has a subluxation at C23, but if you look at the spinolaminar line, it is intact. Whereas this is another child with C23 subluxation again, but you can see the Swiss check line is broken at the level of C2. So when you are not able to suspect or diagnose a fracture from a radiograph, don't go for a CT straight away, you can go for an MRI, because in most of these children, injuries involving the soft tissue alone can be higher. So that brings us to scivora, spinal cord injury without obvious radiological abnormality. In children less than 8 years, it can happen up to 20 to 40%. The premise here is that the spinal column can stretch up to 2 inches, the vertebral part, whereas the spinal cord will get ruptured if it is stretched more than 1 centimeter. So management of these scivoras, it's typically treated non-surgically, and the main predictor outcome depends on the neurological status at the time of presentation. So this is a boy, 7-year-old boy, who presented with neck pain and monoparesis. There's a small fracture at the level of C5, but if you can see in the edema, there is cord edema. He was treated conservatively and had good outcomes. Whereas this is another 5-year-old child who was paraplegic below C7 level, and we are not able to visualize a fracture at the level of the cervicothoracic junction. But the MRI shows, though the vertebral column is intact, there is complete disruption of the cord at the level of C7. And grossly unstable injuries are more common in more than 10 years of age, and they are pretty much treated similar to an adult. And one thing I want to tell about in adolescents who complain of severe back pain and radicular pain after a twisting injury to the lower back is the end plate avulsions. So the MRI is typical of a disc herniation, but if you have a CT, there is end plate avulsion at the level of the end plate. So in summary, pediatric spine injuries need a different approach. So I would like to highlight again the 8 years thing, where there is a different biomechanics, higher mortality, more incidence of cervical spine injury. But more than 8 years, you have more of an adult pattern. So know about the normal variations, the synchondrosis and the pseudo subluxation. When in doubt, try to get an MRI. And management, try to individualize for each of these fractures. Thanks for your kind attention.